Hello, my name is Michael Brooks. I'm an assistant professor at Baylor College of Medicine, and today I'm going to be presenting our prostate cancer active surveillance in 2020 discussion. So in this talk, I'm going to cover basically how we're integrating MRI Fusion Biopsy into our active surveillance protocol using best evidence. We'll cover a number of different topics, including prior North American cohorts and outcomes before MRI, MRI fusion biopsy and biopsy naive men. Can we do away with the diagnostic systematic biopsy altogether? MRI fusion biopsy and the confirmatory step, can we again do away with the systematic biopsy at that point? We're going to review the evidence-based continued surveillance protocol that we use and special considerations, and then overview a few cases with some pitfalls that we've run into. So two large prospective cohorts with long-term follow-up in North America, the Johns Hopkins cohort and Toronto cohort, both with slightly different outcomes. The Johns Hopkins cohort, again, being predominantly very low-risk patients, and Toronto cohort including some Gleason grade 2 men in their follow-up. 5 men developed metastatic disease in the Johns Hopkins cohort and only 2 prostate cancer deaths, but this was with almost 2/3 of the patients undergoing some form of treatment during their surveillance. The Toronto cohort with 28 men developing metastatic disease, but almost solely in men who developed Gleason grade 7 or higher disease prior to their clinical metastasis. This cohort with only a 55% 15-year treatment-free survival. So slightly different outcomes, slightly different risks, but both cohorts achieving excellent outcomes without any of the genomic tests or MRI technology that we have available today. So that really begs the question, how do we use today's tools to improve risk assessment and safely expand the active surveillance entry criteria? Well, the NCI cohort, this was the largest cohort published in 2015 in JAMA, really broke open this paradigm where targeted biopsy can diagnose more high-risk cancers, and by adding trust biopsy, you may diagnose more cancers, but there will be predominantly the low-risk variety. Majority of these men had undergone a prior biopsy that was negative before entering into their study. And followed by that, there were 2 large prospective trials in biopsy naive men, the PROMISE trial and PRECISION trial, both demonstrating very high sensitivity for MR fusion biopsy in diagnosing clinically significant prostate cancer above 90%. Slightly different trial designs. So in the PROMISE trial, men underwent a multiparametric MRI, and the MRI findings were compared to the histologic findings on a template mapping biopsy. There was no actual fusion biopsy performed in this trial. In the PRECISION trial, 2 arms, one arm men underwent an MRI, and if they had a visible lesion, they underwent a biopsy. There was more clinically significant prostate cancer diagnosed in that MRI arm versus the other arm where men just underwent a truss systematic biopsy. It was a non-inferiority study. However, we don't know anything about the men who did not undergo biopsy that had negative MRIs in the MRI arm. Additionally, the PROMISE trial makes the assumption that an MR fusion biopsy would achieve similar diagnostic accuracy as their template mapping biopsy, which again is a bit of an assumption. So the MRI does improve the biopsy accuracy. Can we forego a diagnostic systematic biopsy altogether? 2 recent trials published, one in JAMA Surgery and other Lancet Oncology, highlighting the paired CAP study. This was a UCLA study of 300 biopsy naive men. 248 of the men had Gleason, or excuse me, PIRADS 3 or greater lesions and underwent a systematic biopsy, cognitive biopsy, and software fusion biopsy using the Artemis system in the same setting. 70% cancer detection rate with either the systematic biopsy with the cognitive fusion or software fusion, which was better than any single method alone. However, up to a third of the clinically significant prostate cancer would have been missed with a single method. And 15% of men with negative MRIs still had clinically significant prostate cancer. These findings were very similar to the French trial MRI First. And highlighting in this figure, you can see there was a significant distribution of cancer detection rate depending on the PSA density. So the PSA density remains a valuable tool in prognostic tool in determining what these patients' baseline risk is. So if the MRI biopsy improves systematic biopsy in the diagnostic phase, can we get rid of the systematic biopsy altogether in the confirmatory phase? Three studies performed in the North America Centers of Excellence, UCSF, NCI active surveillance cohorts, and the ASSIST trial performed in Canada. All of which demonstrated some superiority in diagnosing clinically significant or Gleason grade 2 or higher prostate cancer using MRI fusion. However, in all three studies, there was potential for missing Gleason grade 7 or higher with fusion alone. In an additional 2 cohort studies, one out of Mass General, 504 men underwent MRI and systematic truss biopsy, 35% of which were on an active surveillance protocol. Up to 19 to 45% of men with clinically significant prostate cancer will be missed with fusion biopsy alone at the time of the confirmatory biopsy. Why is that? Well, it's because the 2 biopsy methods miss in different locations. The MRI fusion biopsy tends to miss in the dorsolateral location that is so well sampled with a standard truss systematic biopsy. And vice versa, the systematic truss biopsy tends to miss these anterior central lesions. Both techniques, however, you have to be very careful and adequately sample the apex because there is potential to miss cancer there as well. Okay, so then this begs the question, if we've done a confirmatory biopsy with MRI fusion or a diagnostic biopsy with MRI fusion, are surveillance biopsies even necessary in the age of MRI? 2 studies recently published out of the UK, both with very MRI heavy protocols. This first study was 672 men that underwent MRI and confirmatory biopsy if there was concordance or discordance, between the MRI and their initial histologic diagnosis. And then subsequently undergo 2 further MRIs for a total of 3 MRIs within the first 2 years of active surveillance. Their outcomes, their long-term outcomes, were fairly comparable to what we would consider a higher risk active surveillance cohort. However, again, whether or not this is feasible in an American system is questionable given the extensive cost of MRI. In addition to that, there was a recent subgroup analysis of the Netherlands cohort in the PRIUS study demonstrating that the majority of men that develop grade progression during their follow-up will be diagnosed by truss biopsy alone, not on MRI fusion. So there is potential to miss grade progression if you forego the truss systematic biopsy and only go with a fusion technique. How often do we need to repeat biopsies? This has been a matter of contention since the Johns Hopkins cohort demonstrated excellent outcomes with annual biopsies. Is this necessary to safely survey men in 2020. And this was a very interesting modeling study by statisticians from the Fred Hutchinson Cancer Center, demonstrating that there is very minimal benefit biopsying more frequent than every 3 to 4 years versus every 3 to 4 years versus an annual biopsy schedule. So I think that would support a less frequent biopsy method. So special scenarios, active surveillance for men with high volume Gleason grade 1. Well, very little is known about this, and that's predominantly because there's a lot of definition variability between guidelines and protocols for very low volume disease. The NCCN and the AUA guidelines seem to be in fairly good concordance, where fewer than 3 cores or less than 50% maximum core involvement. We do know that men that develop an increasing number of positive cores during their surveillance, or percentage of positive cores, will later go on to develop grade progression, and even an increase in the percent core involvement, or the length of the cancer involvement, is also strongly associated with later grade progression. So a word of caution there for men with high volume Gleason grade 1 disease. Another hotly contested topic, Gleason grade 2 disease, whether or not it's appropriate for active surveillance. This is a 15-minute to 20-minute talk in and of itself, but just to highlight one study out of Toronto, looking at 732 men with low-risk disease versus 213 men with intermediate-risk disease. With long-term follow-up, 10 to 15-year follow-up, there is a significant difference in metastasis-free survival between these two groups. The Gleason grade 2 and 3 men do significantly worse than Gleason grade 1 cohort. So a word of caution. Active surveillance for African-American men. African-American men have historically been less likely to be enrolled in active surveillance protocols. This is demonstrated through a Medicare SEER study, but recent study from the Canary Pass cohort demonstrated no difference in progression or treatment-free survival within the first 6 years of follow-up. And additionally, men that underwent radical prostatectomy, there was no difference in adverse pathology between the African-American men and Caucasian men. So I think the African-American men absolutely should be included in the active surveillance discussion. So this is our current active surveillance pathway. Due to resource limitations and just basically efficiency in our clinic, we tend to do a systematic truss biopsy prior to the first MRI. The benefit of this is that some of the intermediate or high-risk patients that don't actually need a fusion biopsy will have already been selected out. And you'll reduce the number of MRI prostates that you need to do for surveillance purposes to only the men that were diagnosed with low-risk cancer, or for men that have a clinical high suspicion of cancer, but were not diagnosed on systematic biopsy. So we reserve our MRI of the prostate for the second stage, the confirmatory biopsy. And then men that, again, have both a confirmatory biopsy using truss, systematic biopsy, and MRI fusion that remain low risk. These are the men that we enroll in our active surveillance protocol with repeat biopsies every 2 to 3 years or sooner if indicated by a change in the PSA density or the DRE. So a couple quick case presentations. First off, we had a 65-year-old African-American male with minimal comorbidities, otherwise healthy, presented in 2017 with an elevated PSA, no other risk factors, and his PSA continued to rise just slightly on repeat testing. His DRE was benign, but a 30-gram prostate indicating fairly abnormal PSA density. He underwent an initial truss prostate biopsy. There were no visible lesions on the ultrasound, and the path demonstrated only high-grade PIN with the remainder of the cores benign. His PSA density, again, using the Tress volume, was quite abnormal, 0.21. So a guy that you continue to have some suspicion. His PSA rose again just slightly, and at that point we chose to perform an MRI. MRI demonstrated a left transition zone Peyroud's 5 lesion that was 2 centimeters in the greatest dimension, that was very anterior. He underwent a systematic prostate biopsy using cognitive fusion, which again demonstrated only high-grade PIN. So again, with further follow-up, his PSA continued to rise, and the lesion continued to be very prominent on his MRI study, which we'll review in just a second, with the potential for extraprostatic extension. So looking at the T2 weighted images, you can see some hypoattenuation in the anterior transition zone, but it's very clear here on the diffusion weighted images, the bright signal in that left anterior transition zone, quite a large lesion that was unfortunately likely missed during a cognitive fusion. And here's the ADC map, again showing loss of signal there in the anterior left transition zone. So now with URinaV fusion biopsy, we were able to target this area with a little bit more confidence than cognitive fusion alone. 3 cores were positive for Gleason 3+4 grade group 2 disease. The gentleman chose to undergo a radical prostatectomy. Indeed, there was extraprostatic extension as indicated by the MRI. However, he had a good outcome and his postoperative PSA was undetectable and he remains continent. So this is an example of a man that we continue to have high clinical suspicion, and therefore we're persistent in pursuing a repeat biopsy in this patient. The MRI findings were consistent, but unfortunately with a cognitive fusion biopsy, we weren't as successful with our URinaV fusion biopsy. One other quick case example. So a 69-year-old African-American male with several medical problems, including a history of colon cancer, treated with chemo and surgery, presented with an elevated PSA but no family history. Again, a normal DRE, 30-gram prostate, but an abnormal PSA density. His initial prostate biopsy demonstrated only 1 core positive, a Gleason grade 1 disease. 10% of the core was involved. So other than the PSA density, this gentleman would be an excellent candidate if the confirmatory biopsy demonstrates similar amounts of disease for active surveillance. So according to our pathway, he underwent an MRI prostate and demonstrating several low T2 signal intensity lesions that corresponded with low intensity on the ADC map, both Peyroud's 4 lesions, but very small, as I'll show you here in a second. So you can again see in this area of the left posterior mid-gland, the loss of signal there on the T2 image that was a bit abnormal. This corresponded with the loss of signal on the ADC map in 2 very small discrete areas of the mid-gland and apex in the medial portion. So these very small lesions can be sometimes very difficult to biopsy with fusion alone. And this is where I think an additional systematic biopsy can be very complementary, because you can guide your systematic biopsies in this general area of where the target lesions are as well, in order to improve your coverage of where the potential cancer is. So on the fusion biopsy, both the Peyroud's 4 lesions were sampled. However, only the left medial base was positive. This was Gleason grade 5 disease. However, an additional left medial apex, and maybe this was due to registration error or just patient motion or just user error, but a additional left medial apex biopsy was positive for Gleason grade 5 disease. Obviously, now with this information, this is not a patient that's consistent with active surveillance. He elected to undergo radiation therapy. So again, another example where a systematic biopsy is complementary to your fusion biopsy and provides additional information. Thank you for your attention. I hope you enjoy the remainder of the conference.